California Pediatrics, a podcast by pediatricians from the 4 California chapters of the American Academy of Pediatrics, AAP California Chapter 1, 2, 3, and 4. 4 chapters, 1 state, 1 voice. In 4, 3, 2, 1.
Hi, I'm Dr. Eric Ball, pediatrician in Southern California, and welcome to California Pediatrics, where we discuss topics of interest and spotlight on the professional trajectory of our guests.
And I am Melissa Ruiz, a general pediatrician in Ventura, California, and our guest today is Dr. Nicole Webb. Welcome.
Thanks.
We're going to be discussing how we can use our voice to advance child health, and I know that you've had a lot of experience doing this. But first of all, as Eric mentioned, we like to hear what kind of meandering path took you to where you are today, to really just get a sense of your career trajectory and understand, how you got here.
So I am one of those people who has known that I wanted to be a doctor forever, literally forever. I had a childhood friend who passed away from leukemia when I was in elementary school, and I just decided that I wanted to be a doctor someday, and I for many years thought I was going to be a pediatric hematology oncologist, and I think I must have written my med school application essays about that because it was still following me kind of years later in residency. But I pretty quickly realized, so I always knew pediatrics, I was very proud of that identity, and then I matched into what was then the child health advocacy track at UCLA, so a really dedicated, very robust advocacy residency, and I had such an amazing time over 3 years, learning a lot of really foundational skills in advocacy, and I was convinced that I was going to go work at a federally qualified health center and be an outpatient pediatrician, and in a somewhat sort of, I can look back now and laugh at it, kind of condescending, patronizing way, save the world one patient at a time. Then I started moonlighting as a third year, and it just seemed overwhelming how many different things go into your typical outpatient visit, especially for our most underserved kids and all of their unmet social needs. And I felt for myself that I wasn't able to do adequate justice to all of those things in the time constraints of that, which was kind of a crisis of faith for me. And I went home and talked to my then fiance, now husband, about it. And he pointed out that I seemed happier when I was on inpatient rotations. And so I had this moment of realization that I could do advocacy work and really care very meaningfully about sort of child health equity before we were using the term, because I'm old enough that I predate the term child health equity. But still sort of care for a population that I found intellectually more manageable on a daily basis and more stimulating. And this kind of led to me looking at hospital medicine jobs. I kind of thought maybe I would try it on for a couple years. At the time, it was really, really common for people to take a hospitalist job for, a year or two while they were figuring their life out. Still fairly common to do that, but for maybe different reasons now. But I wanted to work with that sort of same type of a patient population that I'd had in my free clinic as a resident. And so that's how I ended up in Fresno, serving a very underserved population and doing really wonderful advocacy work while being an inpatient doctor.
So you didn't do a fellowship?
I didn't, no.
Oh, I didn't realize that.
Were you seeing things in the hospital in Fresno that you particularly geared your advocacy towards?
Yeah, so for starters, the Central Valley of California, you guys, we're recording this today, but you guys hear me talk about this all the time, is one of the most medically underserved parts of the country, really, truly of the whole country. But a lot of folks are not aware of that, even in California, let alone in other parts of the country. And so the rates of obesity and food insecurity and intergenerational poverty, where you have families that have been living in poverty for multiple generations, as well as a very, very large and very, very racially and ethnically diverse immigrant population, a very large undocumented population. A lot of folks who have are either underinsured or uninsured, and so the majority of the patients that I took care of in the hospital were publicly insured or uninsured, and often presenting very late with common things that had become more problematic. A lot of families that had actually made their way across the Mexico-U.S. border and come as far north as Fresno because they knew that was a place that would sort of welcome them, and there were so many issues, but a lot of them really stemming from the sequela of poverty and lack of access to care, as well as I think the intersection of that with a very kind of individual rights oriented sort of social milieu and a lot of kind of higher incidence of preventable injury, and that really sparked my interest in injury prevention in particular. but always from a sort of like, who's being disproportionately affected by this lens.
I'm correct that you started or worked on starting the hospitalist fellowship in Fresno, right? So can you talk a little bit about that? Because I'm just thinking about the intersection between advocacy and medical education. And
Yeah. So I mean, always loved advocacy, always loved education. And one of the reasons that I chose the job that I did when I was finishing my training over a couple other opportunities was that they did have residents, and I knew I'd be able to work with residents and medical students, but in a manageable capacity as a new grad. And so there was always that kind of interest there. And then I, joined this really robust division of hospitalists that had been around for quite a while at that point, right at the moment where nationally we were starting to have conversations about advocating for our field to be a recognized specialty, and how very different it is from what both of you do as outpatient pediatricians. And so I was really fortunate to kind of be part of some of those conversations, and to be able to kind of take my advocacy skills and actually advocating for the necessity of a training program, which was its own sort of challenge, and a lot of leadership skills and lessons, like hard lessons learned along the way. But really, what we do in hospital medicine is pretty distinctly different from outpatient pediatrics at this point. And to be able to support the continued growth of the field, there was a lot of interest in growing fellowships, and we kind of at our, my former institution viewed that as a way of also hopefully giving back to the community and increasing the capacity to care for hospitalized kids, which was how we ultimately were successful in negotiating for that. And I got to not only be more engaged in teaching, but do a lot of other stuff I love, like building things and tinkering with things. My husband always loves to point out how I'm like always tinkering with something. Like I love a problem. I might complain about the problem, but I also would rather have something to work on and fix than sort of be in stasis. And there's medical education is just, it's very challenging, but there's always something that needs your attention. You're a program director, so you know that as well. And you're never bored. And I really love that. And also it's just a really great way to hopefully instill the next generation with the skills to kind of confront today's problems. I think that the conversations we're having now and the problems that we're addressing aren't totally different than when we were in training, but they have evolved, and we have to make sure that our skill set evolves to kind of keep pace with that. And so when I'm feeling frustrated about the state of child health or the state of the world, one of the ways that I feel like I'm making a meaningful contribution that helps kind of counteract the nihilism is in hopefully equipping the next generation that's going to follow us to be more prepared to confront all of those challenges.
Can you talk about some of the programs or interventions that you guys worked on at your time at Valley Children's?
Yeah, so a lot of work around injury prevention. So that region is very hot, and even among folks who are lower resource, there's, so not everyone has a private pool. Certainly the more affluent do, but you'd be surprised how many people who are actually of more reasonable means who also have pools. And, at the time that I started working there, there was very little traction. I'm not responsible for this. I should preface that. You can edit it out if you like. But there was a lot of evolution over a period of about 20 years in the recognition about the importance of water safety. And so some of the folks at my institution had done really amazing work, actually, legislative advocacy, community participatory work, all the things that we talk about and we get so excited about in the AAP, to really create a broad coalition and garner support for water safety. Some of which, by the way, was in partnership with Southern California and particularly the Orange County chapter. A lot of the folks up there are good friends with Phyllis A. Gran. And so there was this kind of recognition of the importance of drowning prevention. And we actually were able to show, again, this predates me, a meaningful reduction in child water-related injuries. And so when I joined that institution, there was this huge coalition of people really interested in injury prevention who previously hadn't really talked about things like poisoning prevention as much, suicide prevention, gun violence prevention. And so it's easy to make it, it sounds nice in a podcast type of a setting, but really over about 10 years built a really, really broad coalition of community groups, faith leaders, healthcare providers from more than one healthcare organization, city council, the then chief of police, first responders, educators, to really talk about how we could address gun violence prevention and how we could really focus on safety and sort of stay away from some of the aspects of that topic that tend to shut down conversation. And Again, I don't have, the data to show a reduction in pediatric gun violence in the region, but I was a really, really meaningful experience in coalition work and sort of reaching across ideologic and sometimes political divides to have conversations that are actually focused on safety and focused on health and not so much on like buzzwords and intense emotional reactions.
Yeah, and words that divide us. Yeah, absolutely. I spent many years in Chicago and some time, in surgery and doing trauma. So gun violence being the leading cause of deaths in children is very real and was very much a part of my life then. Luckily, not as much now, but I think I really appreciate all the work you've done in that space. So thank you. I was wondering how much of the advocacy training you embedded in the fellowship, and then now that you're a program director for a residency program, how that's looking.
Yeah, so one of the things that I was really excited about in sort of being able to build, a program from the ground up is like being able to sort of add in those components that I think are not just meaningful to me personally, but really important and skills that are not often taught. And so we had a large advocacy focus in the fellowship program, but it sort of nested within an organization that because it serves such a vulnerable population, advocacy is very central to the work that my colleagues do there. I remember talking to people about, are you interested in advocacy? Do you do anything with the AAP? And a lot of kind of blank stares when you say like capital A advocacy to people, but then you look at kind of what they're doing on a daily basis and, programs to address like interventions for autism, for families that prefer a language other than English, or again, all the injury prevention work. A lot of focus on like perinatal mortality in vulnerable populations and things like that. So they were doing this really, really meaningful advocacy work, and we felt like it would be inauthentic to not bake a lot of that into the training program. And then I am fortunate to be part of a national work group that is looking at how we can increase capacity for pediatric hospital medicine fellowships across the country to provide advocacy training. So like there's some of these topics that are really evergreen, like how do you write an op-ed and how do you talk to a legislator, and these things that do you really need to have, does every single program need to reinvent the wheel, or could we sort of create resources or even leverage existing resources to be shared? Because what we found when we surveyed program directors nationally is most people think it's really important, but they're not really sure where to get started. And it's not just time, it's kind of availability of faculty that are comfortable mentoring, familiarity with the concepts and sort of how to teach them. And so that's been one way of advancing.
And I think the diversity in what people are getting in residency, right? Because people are going to come in such different places. Yeah, absolutely.
Do you have any advice for people who are in medical education about how to convince hospital administrators or people who kind of make policy or provide the finances and the resources for your program to engage in advocacy? Because it's more of an altruistic experience, right? You're not bringing money into the institution by having advocacy training. And also there's a limited amount of time where you can train someone to be a hospitalist. So how do you blend and mix the clinical responsibilities of the institution with the need to advocate for your community?
Well, I think for me personally, I have always sort of found time for the things that lead to a net improvement in the frustration, versus productive kind of outlet for that frustration sort of ratio. And so I have historically done a lot of that on my own time. And one of the things that we talk about with trainees, and even in the academy, is it's important to know kind of who you're representing. Are you representing the AAP? Are you representing your institution? Are you representing yourself as an individual? So a lot of that work I think was done independently. But speaking as Melissa and Eric, as you both know, I moved institutions recently, but speaking in terms of my previous institution, connection to the community and sort of to the mission, which is really to serve this incredibly vulnerable population and to try to improve their overall health, was typically a good starting point. And then they were very focused also on trying to retain people within, within that region. And so we really kind of intentionally crafted the mission statement of the training program, both the residency, which I did not start, and the fellowship, to be focused on like caring for this population in this region. And, I think that was part of it. And then knowing what the currency at your institution is. So again, that varies from place to place. And in academia, it's not usually compelling. You don't sort of advance along the promotion trajectory typically for advocacy work, but in a very community-oriented setting like where I used to work, familiarity with, the work that the hospital is doing outside of patient care was very meaningful. And so I, as much as it may not seem like it right now because I'm nervous, like was on the news all the time and, would be the sort of trusted person to speak to issue X, Y, or Z. And they knew that they had a person that they, could call on. And it was sort of like my willingness to say yes to a lot of those asks that benefited the institution sort of gave me a little more capital when I was then kind of negotiating for things that may not be as immediately apparent in how they would benefit the institution. But I think things that demonstrate your investment in the community do matter, particularly in a smaller setting like that. I work for a very large organization now, and they have 15 different people that already kind of maybe are the face of those things. And so one of the things that I've been kind of focused on this year in that new role is like finding my space, and it doesn't really matter who's speaking as long as someone is. But in a smaller, more intimate environment, I think it's easier to have conversations face to face with leaders, with administrators, with people who maybe have very different roles, who might even hold very different viewpoints. And when the need is there in terms of trying to address issues that we're seeing day after day after day in terms of the clinical outcomes of our patients, and like resource utilization is another one. Talking about how if we could get out into the community and sort of advocate about a lot of these issues, we may see a reduction in some of those non-urgent complaints coming through our emergency department and things like that. That's I found to be sort of a more helpful frame than just do it because it's the right thing to do.
Yeah, absolutely. I think I'd love to hear, you mentioned injury prevention, specifically gun violence prevention. It's something I'm going to admit, and I think I've sat through a couple years of you telling us how to do it. I'm still not great at it. I'm not great at talking about it with patients, and certainly not great about talking about it on a larger stage, even though I've seen really bad things from guns. So could you give me a little primer, and our audience a little primer?
Yeah, well, so first of all, we're all, we're sitting here at this like gathering of national leaders of the AAP, which every year I find this meeting to be like rejuvenating and like a reminder, of my purpose. And so there's tons of other amazing thought leaders that, you could ask that same question to. But I think a lot of our conversations at this meeting have been about focusing on the common ground, right? And there's always common ground, and not losing sight of that in the sort of noise machine and the polarity of the world that we live in. And that common ground is safety. And I have a lot of talks that I've given on this for different settings, audiences. But my favorite one is called The Only Lane is Safety. So a few years ago, I'm sure you guys remember this is our lane movement. And it is our lane as pediatricians. It's absolutely our lane to talk about things that impact child health and impact safety. But that still kind of was a reaction to being told it wasn't our lane, which still kind of brings the conversation to this sort of more polarized place, as opposed to there really is only one lane. There's not multiple lanes. There's not multiple teams. We're all team safety. I believe all of these different entities that, maybe advocate for more ready accessibility of guns don't actually want children being shot to death. They don't want this to be the #1 cause of death of U.S. children, right? So I think you have to focus on the safety, and you have to believe that, and you have to believe that it's not a controversial thing to ask about. And that really does take practice. But just like we ask about all these intimate details in it, like an adolescent assessment, for example, like you walk into a room, especially if it's like an establishing care visit and it's a teenager, you're gonna just now ask all these questions of a person that you have just met. This is really no different. Talking about that coalition that I built in Fresno, one of my best friends there is a seasoned injury prevention expert, and she had never touched this topic. And I broached the issue about 10, 11 years ago now. And there was like this aha moment, and then she became the biggest poster child for it. And her favorite thing to say about it was, it's only weird if you make it weird. Yeah. And so I think it has to start from like, there is a reason that I'm asking this question. It's important, but I'm also going to listen. And the AAP has done tremendous work in this space. And the 2012 version of the policy statement talked about how the safest home for a child is one without a gun, which by the numbers, like objectively, we know is true. But it didn't really address the myriad reasons why American parents may choose to own firearms. And living in a region of higher gun ownership, and I think a little bit of a different socio-political milieu than some of the other parts of California really forced me to kind of confront a lot of my own biases and to think about, to really think about why am I asking this question? So I didn't think it was weird at all, but why am I asking the question? What's my goal of the conversation? Should I maybe listen to these parents and kind of understand where they're coming from? And so that does take time and it takes practice, but I think you have to believe that it's not a weird or inappropriate thing. You have to be really invested in what what they tell you, and then you base the rest of it, the safety counseling, on what they tell you, right? And what their reason for owning a gun in the first place is.
What's your advice for young pediatricians, trainees, medical students who want to get into advocacy? Like, how do you take that first step?
So come to, listen when your program director is like sending you emails about this. No, we do try to do an overview session to the AAP specifically, and kind of how they're automatically members, right? So a lot of people don't know this, but every medical student, you guys obviously know this, every medical student and resident and fellow is automatically a member of the section on pediatric trainees. And so it's an existing resource that does this well, but it's very nebulous to most people. So the point of that session for us is to kind of connect the dots a little bit, and then to use some tangible examples of work, that I've done, work that some of my colleagues have done, and to just like invite them to come, to come along when we have meetings, particularly if they're not outside of working hours. So residents are not, the era of kind of showing up to the 6 p.m.
No, it's over.
Thing has passed us by. But when we have things that can be during the day, or we can invite, we've invited a couple of our chapters, like very prominent advocates, to come give talks at our academic half day, which in a virtual era, the person could like zoom in from almost anywhere. And to kind of, we actually had Dr. Owen, who's the chair of the Council on Community Pediatrics, gave a talk on juvenile justice and the work he's done in that space.
Oh, that's great.
Just a couple weeks ago. And it was very much this aha moment. We had Dr. Gutierrez, the former chair of the Council on Immigrant, Child, and Family Health, did a talk on his work in that space, and it was just like watching their eyes light up. And I think even though I've done a lot of this work too, hearing from like their program director is not quite the same as hearing from someone who's sort of actively in that space, taking time to kind of come talk to them. So that's definitely part of it. And then I think once they've had some experience, like connecting the things like a lecture to a tangible action. There's a lot of like electronic resources, robo-texting and other things you can do that are pretty accessible. Whenever there's action alerts from the CMA or the AAP, we sort of push those to our residents through an advocacy channel that we have in Teams. We're a Microsoft-based organization. That's really helpful. Advocacy Day in California is a huge way, but I find that they have to have had some introduction to get them to rearrange their schedule, to ask their clinic preceptor to have, that day off to be able to come to Advocacy Day. So we don't wait until May to start the conversation. And for us in the residency program that I oversee now, it starts in recruitment. We're really trying to recruit people who are very focused on advocacy. But even those folks, if you don't give them tangible actions they can engage in easily, that are quickly, that don't take a ton of time, they can kind of get overwhelmed very quickly with the challenges of being residents.
I want to thank you for joining us today and for all you do in advocacy for the kids of California. I think you honor your friend, your childhood friend, who inspired you to become a pediatrician, and I think the lives that you've saved along the way probably made her proud. So thank you for joining us today, and thanks for all you do.
Thanks, Nikki.
Yeah, thanks, guys.
That was so great to have Nikki on. I really enjoy having all of our guests, but particularly guests that I've worked with for years, and always get to learn something new and hear why the passion is there, and it was really great to learn more about her.
I was inspired by her, and I want to do more advocacy. It was fantastic. So that was great.
Yeah.
And thank you all for joining us today in California Pediatrics, and we look forward to seeing you on the next one.